This is the core question of implementation science, in fact, is why aren't these evidence-based interventions translated into practice more rapidly, widely, and sustainably? And so that's exactly what the research is that we do. So I'll just give an example of one of the projects we're working on in the center, and it's about the impact of stigma as a barrier among women in Nepal, where cervical cancer is the leading cause of cancer incidence and mortality, although it's extremely rare at this point in the United States. Again, because we have evidence-based interventions to prevent and treat cervical cancer here. So almost no women die of it here in the United States. But in terms of the global disparities, they're very, very large. It was believed that one of the barriers on the patient side to taking up cervical cancer screening services that are available is stigma. So in this research, first, qualitative researchers spoke to groups of women, many of them illiterate or barely literate, in the hill areas around Kathmandu, Nepal, to find out what was going on. That's something we do in implementation research. We talk to people. We have to find out, why are providers not, say, screening women who come into the facilities? Why are women avoiding screening? Why are women not following up when they're told they have an abnormal screen? Why are women not finding out that they even had an abnormal screen that they need to follow up on? These are all of the sorts of implementation barriers that we research and identify in the first part of the process. Then we were able to translate what's called a stigma reduction intervention. And we adapted that stigma reduction intervention to the Nepali context, working with medical anthropologists and medical providers and so forth to the intervention. Then the fun part comes in for the quantitative people, such as myself, which is we want to test this new intervention to see if it actually, A, reduced stigma based on the scales that we've adapted to assess that among Nepali women, and then B, to see if it improved their uptake to screening. So as statisticians, we have to do things like calculate the minimum sample size that's needed to detect a realistic difference. We have to take into account the fact that the study is taking place in different regions where women are going to different clinics. And within those clinics and regions, there may be different background rates of cervical cancer screening and perceptions of stigma, so that the statistical power of the study has to account for those differences between the groups from one facility or region to another. And then finally, there are different ways to analyze the data at the end of the study. You can compare the change in the control group, that is, those women or regions that were randomized to just go along and do what had already been done, to the intervention group where this new stigma reduction program was applied. So you can compare the change in stigma scores from one group, the intervention group, to the control group. And if there is a difference, and we do certain types of analyses, then we know that the stigma reduction program helped by a certain, say, percent. But there's other ways of analyzing the data. We can also just compare the stigma scores at the end of the study in the intervention group to the stigma scores at the end of the study in the control group and see, are those different? So which method do we want to use? Well, that's where researchers like myself and other quantitative researchers in CMIPS come in. We can do the mathematical calculations to either derive what's the best method to use for this situation, or even come up with a different way of assessing the impact of the intervention that takes into account the features of that study and also provides adequate statistical power.